Hey there everybody, my name's Tim. I'm a third-year resident here at SAMC, and I'll be your guide to hernias today. First of all, let's go ahead and start with some definitions. So you can see the definition of a hernia there, and under related definitions you can also see what I guess you might call states of hernias. A reducible, incarcerated, and strangulated. A reducible hernia is one where you can feel the defect. You can feel something through it. You can feel the hernia itself in the sac, but you can push it and its contents back to the fascial defect that it's associated with. An incarcerated hernia is one in which you cannot do that. A strangulated hernia is one in which the contents of the hernia are at risk, secondary to a compromised blood supply. Alright, let's go ahead and talk about the different types of hernias. There's lots of ways to classify hernias, but in general, one might consider ventral abdominal wall hernias, groin hernias, pelvic hernias, and posterior abdominal wall hernias. The image is a bit small in your paper, so I'll just go ahead and zoom into this for briefly so you can go ahead and take a quick look. Alright, and then to kind of take a step back and just consider why it's important to talk about this as a subject, getting at the fact that although the true incidence is not known, it's estimated that literally up to 5% of the population will at some point in their lives develop an abdominal wall hernia. And that's a rather broad classification, and to note, about 75% of abdominal wall hernias occur in the inguinal region, with a great proportion of those being indirect, and I'll mention kind of more definitions along this line later on. For some hernias there really isn't a sign, but for groin, and in particular indirect inguinal and femoral hernias, they tend to occur more on the right. I'll kind of leave it up to you to look up why that happens. Risk factors for the development of hernias include obesity, older age. They become more prevalent as people age. And things that either increase your intra-abdominal pressure or which weaken the connective tissue of your abdominal wall. The cost of hernia repair is significant, although in this day and age, most hernia repairs tend to be along the lines of same-day surgeries, so the hospital cost incurred is much less than it was, say, a decade ago. Alright, let's go ahead and delve a little bit deeper into ventral hernias. Some of the ventral hernias are so named based upon the region of the abdominal wall that they are contained within. When you read about the layers of the abdominal wall, please keep in mind that depending upon where you're at on the abdominal wall, these different layers may or may not be distinct. This picture depicts in a region of the abdominal wall where they are distinct, and as you can see on the right-hand side there, going from skin all the way down through the peritoneum. Please know these layers, they're important for the repairs and to have a good understanding of what's going on. An important landmark is the arcuate line, which you can see at this arrow right here. Above this line you have all the layers, and most notably the posterior rectus sheath. Below this line, this sheath is no longer there. The mid portion of the intra-abdominal wall is served, and to include the rectus, is served by the epigastric arteries, the superior and inferior epigastric arteries. As you go out way laterally, you start to run into the lumbars and so forth. This image here just kind of depicts how that vasculature kind of travels within the layers of the abdominal wall in terms of the epigastric artery and its branches and so forth. I forgot to put, there's kind of a map of where the nerves go, and you can kind of see that layer of nerves there. It's important to know how those sensory nerves kind of fan out from the back and come around anteriorly. Incisional hernias account for a significant portion of all abdominal wall hernias, and these are acquired hernias generally after some sort of incision. After midline laparotomy, the incidence is certainly not insignificant by any means. The natural history of ventral hernias isn't quite clear. We have data for inguinal hernias, but it's unclear whether you can kind of apply that to the ventral hernia realm. Most would repair a ventral hernia if it was found unless there was some sort of contraindication. There are multiple types of ventral hernia repair, which are defined by where you place the repair. Inlay repairs are within the defect itself. Overlay repairs are over the defect. Preperitoneal repairs are in the space just anterior to the peritoneum. Intermuscular repairs are self-explanatory. An underlay repair is beneath the fascial defect. And a rectus repair is one that is anterior to the rectus sheath but below the belly of the muscle itself. Outside of special circumstances, it appears that an underlay type of repair is associated with a lower recurrence rate than was found historically. Alright, let's go ahead and talk about umbilical hernias, a subset of ventral hernias. And I like to break these up between infants and adults. In infants, you have these congenital hernias that are common and which generally close by 2 years of age. Those that persist to school age or about the age of 5 are usually repaired. And there is a higher incidence in African American versus white infants, and complications related to these umbilical hernias, i.e. strangulation and so forth, are generally thought to be pretty uncommon. In adults, these hernias are not generally seen to be congenital but acquired. They are more common in women and are related to those processes that increase the pressure inside of the abdomen. Somewhat interestingly for this and also for other ventral hernias to include the epigastric hernia, there are some people that have a predisposition by having a midline epidurosis that is not quite as robust as it is in most folks. On an adult, if you happen to notice a small asymptomatic umbilical hernia, you don't need to repair it. If it does happen to cause the patient pain, however, or be unusually large, or if there's something stuck in it, or if there's some process by which you're worried about an increased risk for incarceration and strangulation, then it's certainly reasonable and recommended to fix these hernias. Now, if these hernias are really small, i.e. less than about 3 centimeters or so in terms of their diameter, you can potentially close them primarily without risking an unacceptably high recurrence rate. For defects that are larger than this, you should not close it primarily, but obliterate this defect with mesh. There are lots of ways to do this, and there's no good studies to say which one is better. Epigastric hernias are another subclassification of ventral hernias that are found in a reasonable portion of the population, and again are more common in men. They are usually quite small defects, and people generally present to you with pain secondary to incarcerated preperitoneal fat. And you can usually repair these primarily from an anterior approach. A Spigelian hernia is a unique type of ventral hernia that occurs out laterally. It occurs through the Spigelian fascia, which is the aponeurotic layer between the rectus medially and the semilunar line laterally. I'll just kind of highlight those for you. So, right about here, and generally at or below the arcuate line, which is this guy here. So that little blue thing is trying to show you where most commonly you would find the Spigelian hernia. Now it's important to note that because there's muscle or layers of tissue over this defect, you generally won't feel a bulge, and the patient will usually complain of pain in this region. So you'll hopefully be able to obtain some sort of adjunctive imaging that can help you to make a definitive diagnosis. These hernias, when they do occur, tend to have a high incidence of incarceration, so you should repair them if you do find them. Alright, let's talk about inguinal hernias. There's a lot of anatomy in this region, and a lot of it can be quite confusing when you start talking about the repairs. So let's go ahead and just start with the basics. And start with the Hasselbalch's triangle. So Hasselbalch's triangle is defined by the following borders: the lateral border of the rectus sheath, the inguinal ligament, and the inferior epigastric vessels. Direct inguinal hernias happen through this space or through this triangle, like right here, and indirect inguinal hernias happen laterally there. So you can kind of see that there's a potential space there for the direct hernia, and then the indirect hernia basically just kind of follows down this rheumatic cord and down the potential space provided by a patent processus vaginalis. There are a lot of important vessels that run through this area, and to include the epigastrics that I mentioned, and obviously the big daddies, the femoral and iliac vessels that can lead to some problems if you're not careful. There's also a plethora of nerves, which you can kind of see here. Depending upon whether you're doing an anterior approach or a posterior approach to your repair, there's different nerves that you really need to be concerned about. But from an anterior perspective, we really kind of think about the ilioinguinal nerve, the iliohypogastric nerve, and the genital branch of the genital femoral nerve. When you get the chance, you should look up the innervations of these nerves and figure out where they go, so that as a physician, when you have somebody that has pain after a surgery, for example, you might be able to kind of nail down potentially if there's a nerve involved and which one that it might entail. The repairs for both indirect and direct inguinal hernias are classified, generally speaking, based upon from which direction you come to establish the repair. So what you see here is an example of an anterior mesh-based or tension-free repair. And it's called a tension-free repair because prior to the use of prosthetic mesh, there were a variety of tissue repairs, a couple of which are kind of shown below on your paper, and these involved bringing together tissues that in many cases would result in tension on the suture line. This mesh-based tension-free repair was shown to have a significantly lesser incidence of recurrence, which is why this is the most common repair accomplished today. There is one notable exception, i.e. the shoulders repair, that's not shown here. It's done in a specific center out in Canada, which is still a tissue repair, and they report very low incidences of recurrence in their specialized center and with highly selected patients. Despite the fact that tissue repairs are not as common as they used to be, I did want to show you a couple, as they are still certainly applicable in cases where you can't use mesh. The Bassini repair is one in which the internal oblique muscle and conjoint tendon are sutured to the inguinal ligament and beneath the cord. The McVeigh repair is one in which the conjoined tendon and internal oblique are sutured to Cooper's ligament. The pectineal fascia and the anterior wall of the femoral canal. At the lateral aspect of the incision, the rectus sheath is sutured to the rectus muscle and tendon. These are kind of hard to understand, so the best thing to do probably would be to just kind of look at them on your own to kind of understand the anatomy. Next, we have the laparoscopic repair, and there are two main types of laparoscopic repair: the TEP and the TAP. TEP stands for totally extraperitoneal repair, and the TAP, or TAPP, stands for transabdominal preperitoneal repair. So what's visualized here is an example of the space that's entered with a dissecting balloon or some other sort of dissecting device. It's a layer just anterior to the peritoneum, the preperitoneal space, for which you accomplish the totally extraperitoneal repair. The transabdominal preperitoneal approach is one in which you actually enter the abdominal cavity and dissect off the peritoneum at the region for which you're going to accomplish repair and expose the preperitoneal space in order to accomplish the repair. You'll certainly have an opportunity to see some of these surgeries, I'm sure. The anatomy, when you look at it from this back side, it can be really confusing. And this image kind of helps you to kind of see what is what and how it all plays out, and as kind of a comparison to show you what it actually looks like when you're looking through the scope over here. So please take a good look at that and try to understand that. From this view, the people talk about the triangle of doom and the triangle of pain. The triangle of doom being basically where you never want to go, because if you go, the patient could actually pass. And there are actually horror stories of these sorts of things happening, and for which this approach, this laparoscopic approach to doing hernia repair was seen as heresy for a while, because people were saying, why in the world would you, put the patient at risk for, injuring one of the iliac vessels, when the repairs that we have currently are doing just fine. And I'll kind of get into that argument later on. So from this approach, you basically dissect out the hernia from the backside, if you will, and accomplish reduction of the hernia and so forth in much the same fashion as you would as if you had been doing it from an open anterior approach. So we already kind of talked about Hasselbalch's triangle, and one thing I didn't mention was the spermatic cord. The anatomy of which you should know. There's a lot of important things, obviously, in that structure. And in women, notably, they don't have a spermatic cord, but what they do have in that space is the round ligament. In terms of physical exam for an inguinal hernia, there are a couple of things you want to keep in mind. One is that you should always have the patient try a variety of positions if you can't find it easily, i.e. laying down versus standing up, and then with or without Valsalva. You can kind of feel over the inguinal canal, and also if if that's unsuccessful or unrevealing, to certainly put a fingertip through the internal ring by invaginating the scrotum. It's not a comfortable procedure, but one that's often necessary. And from an imaging perspective, ultrasound is obviously the first go-to. And if you can't see it with ultrasound, it's probably unlikely that you'll see it with CT, but you might see something there that you could not pick up on ultrasound. And if all of that fails, you can have the patient come back for a physical exam after some sort of instigating activity for which the patient complains that he or she has symptoms, or you can accomplish diagnostic laparoscopy as well. Now, in terms of accomplishing repair, one question I always had in my mind was, if the patient has a hernia that they know about, but which doesn't cause them significant discomfort, and it's not a risk to their life, i.e., there's no strangulation or even incarceration, then is it necessary to fix the hernia then and there? Because as we'll see later on, this is certainly not a free surgery in terms of some of the complications that you can have. There have been prospective randomized trials to look into this question, and one in particular evaluated 700 men in a prospective and randomized fashion, and these men had asymptomatic or minimally symptomatic inguinal hernias at the beginning of the study, and they were followed for 2 years. At 2 years, the of incarceration was approximately 0.3%. There was a pretty significant crossover rate, and this crossover rate was usually secondary to pain. Importantly, when these folks did eventually have a repair, they found out that the operative complication rates were pretty similar to those that had just kind of gotten the surgery to start with. So a lot of people had concerns that if you were to let these hernias sit for a long time, they would scar, and people would have a lot bigger problem later on if you just didn't fix it. And it was found that that was probably not quite true. Now, in terms of kind of the different types of repairs and how they compare to each other, in general, again, as I mentioned before, the tension-free repair, that's usually synonymous with a mesh type repair because you're not having to oppose tissues that aren't normally put together. The incidence of recurrence is lower, and again, the outlier is the Schuldeis group and what they do. Initially, it was thought that laparoscopic surgery, while there was evidence to show that there was faster recovery and potentially less pain, and better cosmesis, that recurrence rates were higher. And for the longest time, it was not recommended that the initial approach be laparoscopic, especially since that you can have such tragic consequences if you happen to hit a large vessel or something of that sort. More recent studies have shown, however, that although there is an initial trend for laparoscopic repair to result in more recurrence or higher recurrence rates, after a period of training and familiarization with the repair, those recurrence rates then basically become equal to the open repair. And then in terms of one of the more common, and with that kind of new baseline, one then looks at then comparing how laparoscopic repair compares in other categories of complications and sequelae of the surgery, and they find again that there's generally a more rapid return to normal activity and decreased persistent postoperative pain. However, the initial incidence of transient neuralgias and so forth is actually somewhat fairly equal. And then to compare TEP versus TAP repairs, they've seen that, again with more recent data, that recurrence rates are similar. However, TAP, or the one where you go into the belly and then dissect down the peritoneum, is associated with more vascular injuries and port-site hernias. One thing to note is that people that were in that preperitoneal space tended to convert more often than those who were on the TAP side of things to an open repair. That just kind of reminds me, so in terms of being able to accomplish a laparoscopic surgery, so overall, I guess what we've kind of said then, that it really is dealer's choice almost in terms of which procedure you're going to offer a patient or which is reasonable for a patient, and it more comes down to the experience of the surgeon at hand as kind of the landscape of open versus laparoscopic surgery has changed so dramatically in the past couple of decades. Is to kind of then talk about contraindications to laparoscopic surgery. So basically these contraindications all come down to whether you can safely access that preperitoneal space, because if you're unable to do so, dissecting blindly with that dissecting balloon or anything of that sort can result in significant complications. And kind of while on the topic of complications, here's kind of a list of the different complications and their incidence in open versus laparoscopic repair. Now, just to note, this table does list recurrence as being about doubly high in the laparoscopic repair. This is the study before, kind of that latest study that I mentioned, kind of comparing the two and showing that there's more equivalence as you have an experienced provider accomplishing the surgery. So as you can see, the most common initial occurrence beyond pain is urinary retention. So that's something to keep in mind. If you're taking care of a patient that just had this surgery, they definitely do need to void before they go home. Otherwise, they can have a very uncomfortable problem at home. And then in terms of nerve injury and chronic pain syndrome, so this surgery this is really what I was kind of getting at when I was saying that it's not a free operation by any means. There are a lot of people that have significant chronic pain issues after having the surgery. It's still kind of an enigma as to how you can try to prevent it, because they did studies of where you actually sacrifice, incidentally, the ilioinguinal nerve, and what they found is the overall rate of chronic pain was actually the same. And again, the initial kind of neuralgia, transient pain, the initial transient neuralgia and pain is seem to be equal between open and laparoscopic surgery, but the overall incidence of chronic long-term pain appears to be less in laparoscopic repair. If someone does have neuralgia after the surgery, one should initially treat them with anti-inflammatory agents, analgesics, as the majority of these patients will get better. If they don't, you can try a local nerve block, and if they have a chronic and defined nerve entrapment syndrome, then they may require neurectomy and possibly even revision of the repair to include removal of the offending mesh or tack or whatever it may be. However, unfortunately, looking at some of the data associated with these sort of syndromes, even if you do all of the above, there certainly is no guarantee that the pain will be gone. So it's a big problem. And then in terms of infections of the mesh and of the surgical site itself, They've actually shown that this in an elective repair, where it's a clean surgery, that giving somebody preoperative antibiotics is not shown to be of significant benefit. That includes in the context of placing mesh and prosthetic mesh in, because as you may have heard before in different contexts, if a mesh gets infected, man, that's a big deal, because it's very hard to eradicate an infection from a non-vascularized piece of plastic, basically, right? And when you're messing around with the spermatic cord, you can cause ischemic orchitis and resultant testicular atrophy. Usually what you're doing is messing with the veins in that pemphiform plexus that's inside of the spermatic cord. And it can be obviously a very sensitive issue for the patient, causing a lot of pain and swelling. And this can last for quite a long time and even result in testicular atrophy. But frank need to take out the testicle is very, very rare, and usually get support these patients symptomatically through this process. You can cause damage to the testicular artery itself, and that's a little bit of a different issue. Just kind of as a side note, in terms of pediatric inguinal hernias, I just want to say that you don't, kind of all the paradigms that we've been talking about in terms of mesh and tension-free and this and that don't really apply. For them, you just do a high ligation of the hernia sac, and they usually don't have problems later on. Interestingly, lately, they've been able to accomplish this repair through a laparoscopic approach. It's super, super sexy. If you have a chance, check it out on YouTube. It's just really neat. So anyway, both the surgeries are neat, but it's just really cool how they do it. Okay, let's go ahead and talk quickly about femoral hernias. So as you can see here, it's a hernia through the femoral canal, which is bound superiorly, sorry, it's hard to say, by the iliopubic tract, which, by the way, you should look up what it is. It's not the inguinal canal. Inferiorly by Cooper's ligament, also a very important landmark that you should kind of go back and look at. It's important in both the open and the laparoscopic or posterior approach. By the way, a posterior approach to that repair can also be open as well. It's just potentially a lot harder. And laterally by the femoral vein and medially by the junction of Cooper's ligament and the iliopubic tract. These hernias, in particular, are more common in women. When they do occur in men, there's up to 50% chance that they will, at that time, or will develop an inguinal hernia as well. In women, this probability is around 10% or so. You can repair this problem by a Cooper's ligament repair or via placement of prosthetic mesh. Recurrence is low, and overall, in terms of, because when you're in this region, it's basically the same region as you're in when you're repairing an indirect or direct inguinal hernia. To note, the incidence of this hernia with those hernias is seen to be about 0.3%, but it's thought that potentially the incidence is maybe even up to 15 times higher than this. Okay, now briefly to talk about pelvic hernias, we have the obturator hernia, which is a hernia through the obturator canal, which is formed by the union of the pubic bone and the ischium, and which is generally covered by a membrane. And if that membrane breaks down or weakens, then you get a hernia. Generally speaking, these folks present to you with bowel obstruction and potentially evidence of obturator nerve compression. And in today's day and age, most likely you'll have an abdominal CT scan that will aid in diagnosis of this problem. Repair is not easy and is generally accomplished via posterior approach. The sciatic hernia is that which involves the greater sciatic foramen, and again may present with bowel obstruction. A perineal hernia is one that occurs through the pelvic diaphragm and is quite rare and generally occurs in older women who have had a lot of vaginal deliveries. Now, to kind of finish it off, we'll talk about posterior abdominal wall hernias, which have those wonderful eponyms that people love to quiz you about. The superior lumbar triangle, being known as Grenfeld's triangle, which is bounded by the 12th rib, the paraspinal muscles, and the internal oblique muscles. Then you have Petit's triangle. I'm sure I'm pronouncing those wrong, I'm sorry. That is bound by the iliac crest, latissimus dorsi muscle, and the external oblique muscle. Repairing these defects generally involves a prosthetic mesh. They used to do these with suture type repair. However, given the fact that there's a bony margin to both, doing so is somewhat difficult. Okay, well, hopefully you've made it this far, and thanks for your time and for your patience. I kind of listed a bunch of things here that I didn't really want to bore those folks that are really not interested in surgery, but these are things that if you have any sort of interest, you might want to check out, and they may kind of, or some of the topics are also things that people may ask you about in the OR, or you may see on a test and that sort of thing. So in terms of talking about tests, I just kind of pulled some questions from one of our ABSITE books, and hopefully they'll help to reinforce some of this information. I really do appreciate your time and your patience, and hopefully get a chance to meet you guys in person. All right, have a good day.